Hey, welcome and thank you for joining us for tonight's webinar, Multidisciplinary Approaches and Structured Early Learning in Persistent Pain and Cardiometabolic Health Management. My name is Bertha and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise a continuing connection to land, water and community and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues joining us tonight. There's a list of how CESAHN can support you in your allied health business. You can contact our practice support team on the email below. So I would now like to introduce our facilitator tonight, Carleen Smith, who is a pharmacist and one of the directors of the Central and Eastern Sydney Allied Health Board. Thanks, Carleen.
The Central and Eastern Sydney Allied Health Network's vision is for optimal health and wellbeing for people living and working in the Central and Eastern Sydney region. So we want to ensure that allied health is fully integrated into the primary healthcare system. So the learning outcomes for tonight are to identify the benefits of a multidisciplinary approach to treatment of people with persistent pain, and to identify how to use a preventative framework to reduce cardiometabolic impacts of psychotropic medicines. So our speakers tonight have provided some innovative structure around treatment. Joyce McSwan is currently the Gold Coast Primary Health Network Persistent Pain Program Clinical Director. She's Managing Director of PainWISE and the President of the Australian Pain Society, and also the Principal CPD Director of the Australian Health Practitioner Advisory Solutions. Joyce has pioneered a unique program in a collaborative format to improve outcomes for consumers with persistent pain. Dr. Andrew Watkins is the Director of Programs and Innovation at Mindgardens Neuroscience Network. Andrew has over 25 years' experience working in mental health services. He has a strong interest in the physical health care of consumers that experience severe mental illness. He created and led Keeping the Body in Mind team, which continues to provide metabolic monitoring and lifestyle interventions. It's recognised as a global leader in addressing all physical health outcomes of mental health consumers through groundbreaking initiatives, research, evaluation and consumer collaborative care. I'd like to welcome now our first speaker, Joyce McSwan.
Okay, thanks for this opportunity, Colleen. I'll be mindful of the clock. I'm coming from Queensland, so it's 6 o'clock now. Reason is because I could talk about this topic from here to kingdom come. So I think we best keep to time. So folks, thank you for joining, and absolutely happy to answer questions as well later on. So put it in the chat. Allied health is a really integral part of the health ecosystem, as you well know. So I'll be talking tonight about a value-based model of care, and with the example of a prototype, which is now more than a prototype across some centres in Australia, and it's in the area of pain management. So I was asked to sort of talk about pain, its prevalence. I think it's quite common to many of your practice if you're in primary care, and also looking at how it can affect the person from a very holistic viewpoint, and then the different approaches to managing it, what our current approaches are, and then what are the evidence-based ways of managing it, particularly from a multidisciplinary approach. So unfortunately, the statistics aren't fabulous. These are from the National Strategic Action Plan for Pain Management, which was updated in 2021. And it still really was bubbling around the 80% of people living with chronic pain missing out on treatment. This is largely due to just access. Major centres having tertiary services, but really they're not accessible if you're not in and around tertiary areas. Pediatrics is even worse off. There's only 7 pediatric pain clinics in Australia, and there is none in Tasmania, ACT or Northern Territory. Interestingly, ACT, our capital, actually lacks quite a bit of services, and those from that area may attest to that. Now, primary healthcare networks like this one CES is very integral to community health. And 6 out of 31 of them currently have pain programs that funding due to funding limitations. So there is no pain funding dedicated for programs through the primary healthcare network stream. And one of my advocacy work with with the Australian Pain Society and with my peers, like the patient advocacy body, Chronic Pain Australia, we're advocating obviously to government to look at access. It not uncommonly 20% of all GP representatives in Australia presentations in Australia involve chronic pain. So you just think about your day, if you're a GP, and you sort of think of how many chronic pain cases you might have seen. And if you're an allied health or pharmacist, you can also reflect on how many you see. And I'm sure it's that number, if not more on some days. As you can see there, again, statistics are a bit dire. 1 in 100 patients will actually receive multidisciplinary care referrals to pain specialists, and not just pain specialists, but tertiary centres. And that is truly, concerning, because it's unlikely some people will make it in their lifetime despite suffering chronic pain. And this occurs in less than 15% of GP consultations where pain is managed. So it's not often recommended or referred on by GPs, purely because probably GPs know access is poor, wait times are long, so kind of why bother? 30% of increased opioid usage was seen in the 2009 to 2014 period, primarily because I think pain relievers are sought, and without access, it makes it really difficult to sometimes have relief that is in a quick sort of way that's satisfying, I suppose, for the patient. However, we do know evidentially in science that opioids are single modality and really are not the key to getting patients well with chronic pain. So what is the best evidence? Easier said than done, and easier on a nice piece of paper with lots of colourful triangles than truly done. But looking at this pyramid, you can see that the foundational layers now for managing any chronic disease, including that of pain, and this is quite specific to pain. It was from the AJGP, a well-regarded journal of GP, and it looks at the bottom, the foundational layer. So it looks at getting therapeutic alliance amongst peers and patient, self-management education, screening for red flags, which is really important, considering the biopsychosocial approach. And in fact, now we probably prefer to say psychosocial bio approach. It's less about the biomedical, approaches truly now for chronic pain. And of course, a very multidisciplinary approach, which is where allied health then fit in. And then the second tier you can see there is more on lifestyle modifications, that no doubt come as a result of a foundational layer being a little bit more targeted. And then further up the top is actually more condition-specific treatment. So it's, that could be the joint, as opposed to the joint being down here, investigations galore just for the joint and then forgetting all the other psychosocial stuff. So now embedded in this bottom layer is actually the favor for more multidisciplinary approaches. We'll talk about models of care and design and some of the barriers, of course, when we come to implementing a service like this. But let me just put everybody on the same page and on the same baseline in terms of just understanding how pain is experienced. And I suppose why this is important is because it sets the scene to help us to actually understand and make sense, and that's a really important word, making sense of pain, make sense why we're saying a multidisciplinary approach is truly necessary. So you can see from this picture, and if we just follow the 1, 2, 3, 4, I think it tells its own story. So one, you need a stimulus, obviously, to create a signal. Now, this is purely not pain at this stage. It's just a signal that is eluding a whole heap of responses. And the neurochemical response basically ascends, and this can be macrophage, inflammatory responses, nerve fiber activation responses that basically trigger a whole heap of neurochemical responses that goes to up the nerve system to the dorsal horn. So at number 3, transduction is obviously the stimulation point. Transmission is as it travels up. And then number 3 is at the dorsal horn in the spinal cord, where it changes. So it's gated. The old gate theory comes in here. And it's a gate theory more for illustration, whereby there are gate openers and gate closers. And I use those words because these are sometimes wordings we do use to explain to our patients. So gate openers are those that let, the stimulation through, the neurochemical pathway through to reach the brain. Gate closers are those that reduce and modulate at that point. So, for example, if a stimulation like the pin was actually there, a gate opener would be, say, perhaps bad news. The patient might have bad news at the time, and then there's a whole other flux of neurochemical processes that then reach the brain, perhaps from the limbic area. Alternatively, or a memory of a pinprick that was quite detrimental from the past, for example. So those are contributing factors to accelerating, augmenting the pain response. There could be gate closers, things like sucking on the finger that can produce another alternate sensory process that's a little bit more soothing, for example. So we use sometimes those terminologies in response to the gate theory. But ultimately what happens is the information reaches the brain, and the brain looks at the information, and then it puts an experience of pain out. If it's something that you've seen before, that you're not afraid of, that there's no protection of, then the pain essentially downgrades. However, if the response is heightened, it can be a very guarded response. So if it's a hot fire, you want to retreat, and that pain is really important for protection. If the pinprick was truly a snake bite, then you want to retreat. If it's just a pinprick and you've seen that before and you knew what you did, and there's enough information for you to go, oh, okay, just a pinprick, it wasn't a snake biting me, then you just, rub it, clean it, and proceed. Acute pain, we hope, will just heal within, sometimes 5 days, at the very most 12 weeks, if it is post-surgical, for example, if that. We start to get very concerned as pain prolongs and doesn't resolve quickly, especially for acute pain. So between 6 to 12 weeks of an injury, we call that subacute. And that's very important to keep an eye on. Why is something not healing? What are the risks of it not healing? Are there any red flags? Beyond 12 weeks, it can become chronic. Now, chronic can start to involve a whole different host of different mechanisms. Typically, you can get neuropathic, depending on where the nerve process is affected. So that's injury. You can get nociceptive, which can be chronic or acute. Neuropathic can be chronic or acute as well. But nociceptive is where it happens to a joint, an organ, the skin, for example. So it's obvious body parts that you can, I suppose, define. Then you can get mixed pain. But when it becomes kind of a little bit confusing and hairy is when everything is healed and yet you get a pain sensation. And we now call that central sensitization or nociplastic pain, meaning that this pathway here remains really heightened. And even though this injury has healed, assuming it was something bigger than a nail, maybe a joint that had been broken and it's fractured, but it's healed. What happens is that healed joint, you might have done an investigation and it's like, well, it's all aligned, it's healed. That pathway, though, continues to be upregulated. So the modulation system at number 3 isn't modulating well, and that remains heightened. Now, if that continues to stay heightened beyond that 12-week period, it can become not just chronic pain, but it can become central sensitization, because the body and the brain particularly stays on guard. It stays heightened, it stays protective despite the healing having occurred. So that's why we call it that plasticity. Now, that used to stump a lot of us in terms of, if we came in from the biomedical space, we would look at an MRI and go, well, there's nothing wrong with you. What are you meaning there's pain? And often patients would feel quite stigmatized. So some of the conditions that you may see sitting around this central sensitization area could be things like allodynia. Sunburn is actually a very short-term, short course sensitization, but quite peripheral in that case, where it's allodynic and it's sensitive. In this area, you see probably more like fibromyalgia, the non-inflammatory autoimmune conditions. You might see pain associated with chronic fatigue syndrome. You might see complex regional pain syndrome, and those you will not get anything showing up on a joint MRI. Usually they're quite global, but they can be quite erratic as well, although CRPS, complex regional pain syndrome, does have very certain diagnostics in and of themselves. The nociceptive, as I said before, is pretty self-explanatory. Bone, ligaments, skin, organs. Neuropathic is obviously nerve damage related, like peripheral neuropathy, diabetic related, or shingles, which is acute, or stroke, which can be central. And then, of course, you've got this brain exacerbated pain response. And we now know there is a difference between male and female. We do know there is, in terms of clinically and academically. What we don't have are biomarkers to tell us how to modify, early with a female, for example, but we do know that females do experience pain more and in different ways. Like little girls will have different pain responses to boys, men to women, very similar. We just don't know quite what to do with that information right now. So what's really important at the end of the day is, while we do look at pain classifications, I love this because this was by Professor Michael Nicholas from the University of Sydney. He runs the Pain Management Research Institute there. And you can see this is a pretty old kind of, like a flow chart. And the idea is that when you think about pain and pain experiences more, I suppose, at a more holistic way, other than just, neuropathic, nociceptive kind of explanations, which can be quite biomedical, we want to look at contributing factors, because the brain, for it to output the experience, it looks at all of these. It looks at what activity is being done. Has the patient had unhelpful beliefs and thoughts? Has there been treatment failures? Have they been invalidated? Have they been told it's all in their head? If they're taking medicines, what are they? And are they long-term, or are they going to exacerbate pain? Because we do know that opioids can exacerbate pain. And have there been other psychosocial circumstances? So we do like to teach our patients that the chronicity of pain is involving a lot more body systems as such, a lot more other body networks that actually impact on function. So sometimes you can get physical changes, which are a bit more biomedical, muscle wasting because they're scared to move, weight gain because they're obviously not moving as much, metabolic changes. There can be biomedical joint stiffness changes depending on their diagnoses, but also depending on how they approach pain. There can be also psychological impacts. Depression secondary to pain, or even primary, and then the pain is exacerbates the depression. There can be frustration, anger, poor sleep. Sleep is a really huge one. We do see sleep closely correlated with pain. Medicines as well can make sleep worse as such. Side effects as well, side effects relating to either medications, and that can also create that whole cycle of apathy as such. And then ultimately there's suffering, and then there's a lack of function, which means that there's disability. So this I love because this does help the patient to sometimes see how it's all linked. And depending on what is most impactful for the patient, sometimes this is where we start the treatment or the navigation to plan their pain management. You can see that a single MRI or X-ray is not going to tell you this information. And if we highly rely on that as the only factor to pain diagnostics, we will be shooting very far from the right tree. And I think that is why, welcome allied health, because you can probably already see that many of these other areas are actually treated with the inclusion of allied health. So with acute pain, I mentioned before that it usually resolves, and an early treatment should usually sort it out pretty quickly. And usually it's immediate sort of release treatment if we're talking about oral medications, or it's usually supportive care and quickly getting back to function. Persistent pain obviously requires a lot more polypharmacy sometimes, depending on the type of pain. It can require long-acting formulations to provide a better baseline of pain relief if we're talking about medications. And then again, the obvious differences, short-term versus long-term. One you can stop, obviously, and it tends to be dissipate over time. And the other, basically, you have to make it a lot more comprehensive depending on the contributing factors and impact that usually come with persistent pain conditions or syndromes. And this is why a multidisciplinary, multi-D, just for short, this is why a multi-D network is so important, because there's no way a GP can really have time or day or skill, with all due respect, to fulfill the role of a psychologist or a dietitian or a physio. Sometimes you do feel you're doing it all in one go, but obviously to do it effectively. Now, one of the barriers here, which is, the usual elephant in the room, is it's costly. It's costly to access funding models that are suited for adequate multidisciplinary allied health management. I think that's something we would all sort of easily agree with. In terms of pain management, look, if we were just to talk about pain management and analgesics, typically it's, short-term usage for acute pain of, simple-ish analgesia, we call these. Some are usually available over the counter. And then a lot of supportive care and less of drugs, really. In chronic pain, as I said before, usually we use a few more adjunctive therapies, serotonin, or noradrenaline receptor inhibitors, tricyclic antidepressants, and those basically support the central nervous system, really, in pain modulation. Sometimes if it's a nerve pain, like a neuropathic condition, you can have the more nerve-specific medications like the anticonvulsants, and they can be more targeted, things like pregabalin or gabapentin. Typically, we want medicines that can spare opioids. Something as simple as paracetamol in the baseline dose can actually spare too many opioids being taken. And what we really do want is as little opioids as possible. And we've come sort of from the borrowed, WHO step ladder chart which is kind of borrowed from the cancer pain treatment protocol. And it really has less and less relevance in chronic pain now, because that step ladder is very much escalating, and we just simply cannot do that in pain management with opioids. It will make pain worse, and opioids can increase the sensitivity of pain, which we call hyperalgesia, when more is taken. Though if someone does need chronic pain management at a baseline, we do have more long-acting formulations that keeps them in the the background. Without harping on too much about opioids, which I think the audience would probably be aware of, these are just some evidences that are there, which basically say that, look, opioids are not the mainstay. We, really would like to discourage initiating opioids for chronic pain if needed for short-term acute pain relief post-operatively. There's evidence around that. But really, now with some of the opioid stewardship programs that are also in hospital, they're really trying to stop, opioids being discharged unless there's very close follow-up. And the reason is because the harm and benefit is slanting on the harm. Now, that is not to say that there aren't so-called inherited historical patients who have come from almost a lifetime of opioid use. And for those patients, if they remain stable, non-aberrant, with a single GP, single pharmacy, checked on life scripts, that it's real-time monitoring, that they're compliant. Some who have already become quite dependent on them, not addicted, but dependent on them and function better consequently, then there could be rationalization to reduce to a dose that is acceptable, adjunct and opioid spare where you can, and either do a very, 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 very slow reduction, or maybe a dose that may have to be just kept in the background of. So there are some realities to all very well saying, hey, opioids aren't the recommended. That said, we do not, absolutely do not, and there's no support for forced withdrawals at all. And some patients, we must be mindful, if they've been on high-dose opiates for a long time, historically or otherwise, they can sometimes have opioid use disorder. They can have developed it. So they have to be treated like those of substance use disorder. So buprenorphine and methadone may be the course of action for some of those, course of treatment. Regardless, I don't want to disregard the fact that there are analgesics in pain management. There are topical also. So not forgetting those. There are also adjuvant therapy, as I said, from the modulation aspect centrally. But we do want to avoid benzodiazepines because the combination of benzodiazepines and opioids can increase spontaneous deaths by up to 9 times. Very important. And I suppose without scaring the patient, I think that kind of fact is very important to explain to the patient, because what I find is sometimes patients sort of don't know the reason why, you're withholding benzodiazepines if you are a GP, and they need to understand there is a high risk of spontaneous death, and you do not want that to happen. Or if benzodiazepines are required, then, judiciously small quantities are needed, or treating truly the underlying anxiety that is maybe there in the background. Trauma, anxiety, pain, they're very, very closely circulating around as well each other. So you have to be mindful of that. Now, coming to sort of the more non-pharmacological approaches that absolutely do work. This is critical because, as you saw before in the table of the contributing factors, when there is reduced movement, the brain actually will be putting out sort of alarms, and in fact, they can be pain increasing alarms, let's call it, if the body is static and not dynamically moving. So that's very important. And in chronic pain, often patients have to be supported by a good physio or exercise physiologist that's not doing too much and not doing too little. Depending on the stage of where they're at with their pain management, it's very important that the right type of movements and meaningful activities are being introduced to them, or they can say, oh, it flares me up, I'm not doing that again. So there are movements that strengthen, but there are movements that also desensitize. The type of movements that desensitize someone who's really sensitive or sensitized with pain are things like qigong, breathing. Tai Chi is a little bit more advanced, I must say, although now there's adaptations thereof. Yoga, again, adaptations. Even simple things like dancing is very useful, more as a mood lifter, helps with the limbic system, the dopamine response. It's up. It's very mood enhancing. Breathing is actually critical. You hear the vagal nerve, I think, sometimes in talk. And one of the most amazing things is breathing. We all breathe, and you'll find that with patients with chronic pain, they'll bite their teeth a lot, and they'll hold and they'll guard, and they tension a lot in their muscle system. And that's because they hold their breath as well, because of fear, and because of sometimes high pain threshold. So learning how to breathe with the therapist can be as simple as that. And that's not a major movement or a strengthening process that kind of gets them a bit worried about movement. So movement is actually key, but finding the right provider who understands when to put which movement in is very important. One of the newer areas that we're going into, and it's really shouldn't be a newer area, but because of some of the way, neuroplasticity has happened, we, in our practice, goes back to fundamental movement, so that we start almost at the beginning to try and help patients to move with some fundamentals. So we slow everything down, and things like even walking, relearning how to walk so it's not painful to walk. Now, not forgetting that there are some other modalities that are just simply meaningful. Hobbies can include movement as well, opportunistic movement as well. So parking your car away from the shopping center, further away from the door, can be opportunistic movements. Unstructured tasks as well, hanging up clothes, putting clothes away, simple tasks like that, even, planned in. And also passive approaches. Now, I'm not opposed to these just because they say passive, but they can't be just relied on. You can't just simply go to a massage and say, I've moved an exercise and someone else has moved it for you. There is value in some of these sensorial responses. TENS application to some degree. Thermotherapy is excellent, and low continuous is better. So for longer periods of time, rather than, searing the steak, as I call it, we want to stew the meat. So low continuous heat therapy is lovely and has evidence for musculoskeletal benefits. Cold, again, depending on the type of pain you're talking about. Now, there are some non-drug and slightly sitting more on the cusp of, supplementary treatment that can be very helpful for some people. The evidence around some of these are more on the lower side, but it doesn't mean that if the patient has tried some of these and they feel that it's useful and they can afford it, within reason, they can certainly be incorporated. As I said before, massage therapy, acupuncture, again, these are passive modalities. Aromatherapy isn't, though. Essential oils can be very mood lifting. We see that in cancer therapy. Natural supplements within reason of evidence, curcumin, fish oil, magnesium, there are evidence around that for pain management and inflammation. Reflexology, I suppose, very similar to massage, and other meaningful things like cats, having a pet around, having company, not being isolated. We do see a correlation from the psychosocial part of pain that being lonely does increase pain experience. Nowadays, there's digital tech. So sometimes people will use distraction methods for de-escalating the pain. Now, playing a little Candy Crush doesn't hurt anybody. However, it's not to be relied on for, you can't escape into the world of Candy Crush to be kind of coping with your pain. That would be a distraction therapy that might be just to de-escalate, refocus, and then you go for a walk, do your breathing exercises, do a gentle stretch, for example. That would be a passive active together. So we encourage patients to be creative and to be good problem solvers. Nutrition is very important. I won't go into much detail here, but you can see that seeing a dietitian can be very helpful. Sometimes medications can alter how things taste, what happens in your gastrointestinal tract. Bloating, constipation, those things can affect one's ability to eat. If patients are in too high a pain threshold, they often don't have an appetite to eat, and that can reduce their, not just their weight, but their strength because of muscle loss. And it can also affect their energy levels, which often many patients go, oh, I'm so tired. They might even complain about the pain. They might just complain about the exhaustion level, and then that then exacerbates pain as well. So being mindful of what fuel sources. So our lovely dietitians are awesome there. Now that said, incorporating allied health, you know, movement, exercise, we know which allied health help us with that. Food, nutrition, we know the ones that help us with that, right? Sleep, of course, some patients do need assessment with this, but these are some tips to avoid. Avoid sedatives, alcohol, to you know, manage sleep. Very important that we have a routine, that the temperature is right in the room. Perhaps they are hungry going to bed, and that actually doesn't help a good night's sleep. The lighting, simple things like that. But typically, if their pain is exacerbated at night, it can certainly affect pain relief and pain ability to sleep as well. Sometimes in our patients, we see trauma and nightmares as exacerbating sleep and therefore pain as well. So it's very important to consider holistically. It's not just a matter of having a sedative to band-aid sleep, because that doesn't give you the right quality. So as you can see, time is required to, you know, be spent. So coming back to the topic area of incorporating allied health, you can see there that there's a whole raft of allied health that can be included. Now, not to say that everyone's needed, okay? It depends on the priority of the patient. It may be 2 or 3, and that's enough to support the patient. And sometimes it's ascertained, well, it's always planned with the patient, but it's ascertained perhaps by the patient's past positive experience. Of course, as I said, one of the frustrating things which currently our models don't always fund is sufficient allied health on our basic chronic disease care plans. That is not, those care plans sadly are not disease state-based care plans. They just can't be for chronic conditions, unfortunately. So we've still got a ways to go to get funding systems to actually work well directly in a standardized way across the nation for things like a condition like pain management. So in our setting, we have got allied health who work closely with us within a pain program. So we have a shared vision, we discuss cases, we, you know, kind of have a way of prioritizing the patient's needs in cooperation with the patient. And yeah, we call them helpers of healthcare. Now, I won't talk too much about this because it again just sort of reiterates more the mechanism, some of the funding concerns as well. Coming towards the end of my presentation here now, this is just an example of pretty much the pioneer model that we pulled together. This is a funding program. This is a funded program that is outside of the chronic pain, the chronic care plan management type of services. This is a disease, a true disease state treatment whereby a certain amount is allocated per patient or a range, and that patient is managed within that allocated amount to get a positive outcome for their pain management within a whole allied health team. So in our Turning Pain into Gain program, which we call it, it's fully funded and it is a model that demonstrated to government, and it's well validated, it's been published. We keep encouraging government to try to understand and fund true disease state managed programs so that patients get education, patients get allied health team approach, they can get extra services on top of their Medicare, and they have a plan. So this is not to say that it's a forever deep pot of gold, but it definitely provides patients with something comprehensive for about 6 to 12 months. And then they obviously leave us better equipped and supported. And many of these have become peer-to-peer supports for each other as well. Right now, I've just done a quick sort of summary of what is available. We've got tertiary public, we've got tertiary private, we've got us, which is this health network pain programs, primary health network pain programs. This is by far the most economical, I would say. There are online versions that patients can self-guide, I suppose, but that takes patients who can do that. They have to self-fund that. And there are other regional-based sort of community type style pain programs also. But the middle one is the one where I think is the most ideal in terms of cost effectiveness overall. Our work has shown us that in primary care, it's roughly around $2,000 to $5,000 to manage a patient for about 12 months. Some of our recent work has shown that it provides care closer to home, a nice myriad of allied health supporters, faster wait times, or shorter wait times, I should say. And however, unfortunately, it doesn't come from a dedicated source of funding. It's still a bit of piecemeal and a bit of patchwork. That's compared with tertiary. So you can see the health economics there. Look, we've had some excellent results overall within. These are just results from our program. We studied in that year, 2015 to 2016. We started in 2013. About 252 patients in that year period. We had allied health, contracted about 25 allied health, some clinical team staff members. Wait times were around 4 to 6 weeks. They'd been waiting on the wait list for about 6 months. So some of our awesome results was that we actually managed to reduce hospitalization, which is very attractive to government funding. And basically the cost savings amounted to, up to a savings of 79,000 to even up to the vicinity of 180,000. So what that meant was rather than one patient a week presenting at hospital, it was one patient a month presenting in hospital. Our papers are available there, again, in the interest of time. You can see that it reduces hospital wait times, keeps things in the community, keeps things accessible to patients, and ultimately it makes the patients problem solve their pain. I won't go through the next results, but this was more focused on reduction of opioid usage. And there was a vast reduction in opioids that year that we measured it. And just to finish, before any questions come through, I'll just play a very short video from some of our participants, who actually, these are now leading some of our art programs as well.
Without the program, I don't know where I'd be. It's been 3 years I've been part of the program. Before that, I just felt that I was suffering on my own.
When you live with an invisible illness, especially with pain, no one ever believes you. And the main thing that you'll get from this is firstly validation, acceptance, and understanding.
You're walking around, everyone's telling you you look fine, nothing's wrong with you. And no one knows what you are as an individual, what you're actually feeling, just because you've got a smile on your face.
It's helped alleviate a lot of the isolation.
I might have a big day and I might crash the next, but I know that I'm going to get back up and I know what I've got to look forward to. And with these programs and these activities and anything that you look forward to in your life, your goals, like I'm planning on travelling. And I think it's time now that I can actually go and travel because I can feel I can manage it. And as I said, there's opportunities remotely to be able to talk to someone from the program, or Joyce, talk to yourself, or talk to any doctors. I can do that remotely. So that is just something that is now driven to say the pain is not going to stop me doing anything.
Sorry about the volume there. And lucky they had the words. I think people were probably reading the words. But anyway, you get the gist of it. Yeah, thanks for listening to me. I think I'll stop there so that yeah, if you want to ask questions, you can.
Thanks so much, Joyce. We've got a couple of questions. Acoustic influences on the vagus nerve, like the Safe and Sound protocol, can be highly effective in reducing central sensitivity. Do you know about this?
Yeah, absolutely. I think definitely that, safety is very important, and it modulates and downregulates the central nervous system really. And simple things like breathing, even though it's so simple, it's actually very, very helpful for that vagus nerve system. Actually, believe it or not, the Wim Hof shower, the cold water shower, is also been evidence to show that it does target the vagus system. We do want things to be quite multimodal though, because again, we're not just a vagus system. We are, biomechanical parts, we are from trauma parts, all the above. So you can see that the Safe and Sound protocol really helps to support that limbic system, and that can really help the patient to at least, come to a place that they can manage and then go forward from there as well. And learning so many other coping techniques is very useful as well, going forward.
There's one here from John.
Love the
Did you get that one?
Sorry, should I read the question out?
Yes, I think so. That's a good
Yeah,
idea.
just in case people can't see this. So, John, thanks for your question there. It says, thanks for an excellent presentation. In your experience, what types of communication techniques have you seen work best to strengthen the MD care for a patient with a chronic condition? Is it letters, phone calls, face-to-face? Hard when we all work in different locations. What have you seen work best? Yeah. So in our practice, we usually start by letters to start off with. We do write many letters, but many short letters. Because our program is about 6 to 12 months, depending on the patient's case, we usually start with an intro. Hi, g'day, can you give us some intel, please, if we need, right? Just as a bit of intro. We try and keep things, if best, short. And then after that, we'll add on and go, hey, this is how progress is going. Physio's seen the case, this is where we're at, or medications require changing. These are a couple of things. Can you please, consider? Sometimes we will go to, if it becomes quite complex, or there's things you want to say that isn't written down, that can't be written down or shouldn't be, then it can take a phone call. Now, in terms of phone calls, what I found worked, if you're in allied health, obviously, I take it, John, you're an allied health person, wanting to make an appointment with the doctor's helpful, with the practice manager can be helpful, or with the practice staff to go, look, I really need doctor's time, but I get it that he's busy. Does he have allocated time in his diary to just take these kind of collaborative phone calls? If you get enough MDTs around with the doctor, you can all do a case conference, and then the doctor can actually, bill for a case conference call. But I know in the day-to-day life, it's not always so easy, and often probably they don't bill on that. However, at the very least, yes, you can do that. The other thing we do is face-to-face is practically impossible unless you're having a networking event. However, the other thing we do is we'll write a letter that might be condensed to a certain targeted issue and say, I'm going to call you about this. So at least they've got heads up. Now, we do that for only serious or more, kind of red flags or things you classify as something a little bit more needing that phone call. I hope that helps you, John. Those look like the only two questions that were obvious there. Were there any other questions? I think I've captured that. Were there any other questions?
Joyce, I've just got one. Did your patients actually pay anything for the treatment that received, or was it all funded by the PHN?
Yeah, so as I said, with regards to chronic disease management funding, it's actually quite important. Well, it is important to get the funding mechanism right to be able to do it sustainably or adequately. So yeah, our patients didn't pay because we did have we use it basically from the flexible core funding. It's very tight though, the funding. It's a small funding, so you've got to be sort of very efficient with the funding as well. Yeah.
Could I also ask if and maybe there's some GPs that are in the audience, if they've actually had experience with having a consultation with allied health and perhaps the patient. Maybe we can get some more.
Any comments around that? I think in my experience, while we get some thinking juices happening from the doctors online here, I have seen some really great collaborations over time in my experience. Any comments?
Well, look, Joyce, I think we might wrap it up there. Thank you very much for your time. I know it's been a big day for you coming back from overseas this morning. So we're really grateful for your time. So thank you very much.
No worries. Thanks for having me.
I'd like now to introduce Dr. Andrew Watkins for you.
Thank you. Just a couple of acknowledgements first before we get started. Really like to thank Carleen and Bertha for putting this CPD event together. It's great to be able to speak to you all. And also just a shout out to Joyce. I love seeing people that are passionate about their area of healthcare and really strive to make a difference. And great presentation. Thank you, Joyce, and keep fighting the good fight there. It's great. And lastly, thank you to all of you for giving up your evenings to listening to this CPD event. So as Carleen said, my name's Andrew Watkins and I work with Mindgardens Neuroscience Network. Now, just to really be brief background on what Mindgardens is. So Mindgardens Neuroscience Network is really about translational research in the neuroscience, mental health and addiction space. Our founding partners are Black Dog Institute, Neuroscience Research Australia, South East Sydney Local Health District, and the Uni of New South Wales. And so we bring those areas all together and we focus on translating research into real world clinical activity. I'm also an ambassador for Equally Well, which I'll talk a little bit about more as we go on. I'm going to draw your attention to the QR code on the screen as well. That'll pop up, the same QR code, in some slides later on. But I'm going to talk about a number of resources today. They're all available on our Mindgardens website and are accessible from that QR code. So today I'm talking about an area that's maybe quite specialised for some of you, and that's working with people that experience severe mental illness. So and those illnesses are things like schizophrenia, bipolar disorder, or generally any people that need to take antipsychotic medications. And the reason why cardiometabolic health is so important in this group is because there's a really significant life expectancy gap that people with severe mental illness experience. So we all know, and all Australians know, about the poor health outcomes and shortened life expectancy that Indigenous Australians have, which is a national disgrace. What's less commonly known is that people that experience a severe mental illness have even worse health outcomes. Now, to lay people, when you first tell them that fact, they go, "Oh, yeah, well, suicide would be a reason for that." In fact, suicide is not a very significant contributor to this life expectancy gap at all. what the major contributor is preventable cardiometabolic health diseases are the things that kill people that experience severe mental illness off far earlier than the general population. I'm going to take you through some of the reasons why and what we can actually do to address this issue. So why do we see high rates? Well, firstly, tobacco use. Tobacco use in people with schizophrenia is up between 60 and 70%, which I think the latest data for Australians aged 15 and over is about 8% now. So it's really, I think the public health messages have had a really positive effect. However, that hasn't translated through to people with severe mental illness. What we observe and see people who experience severe mental illness is there's much higher rates of obesity, high blood pressure, glucose and lipid abnormalities, and they're more likely to live a sedentary lifestyle and have poor nutritional intake, leading to excess cardiovascular disease. And also, let's not forget about the poor oral health levels that they have. So that sounds like quite damning and like, why don't people with severe mental illness do something about this? Well, there's a number of reasons that makes that challenging. And first and foremost among these is the medications that people are required to take. So antipsychotics cause incredible weight gain in a lot of people. And I'm going to show you some slides as to how fast and how much that occurs shortly. But when we think about antipsychotic induced weight, with mental illness, it's a challenge. It's a challenge for people to live with it and especially to recover. And when we have this added complication of weight gain from the medications, it makes it much harder for the person to recover and reintegrate into society. It's also an issue around adherence. Thinking about any medication, if there's some undesirable side effects that occur alongside it, well, people are less likely to take that. The problem with severe mental illness is that when people become non-adherent to their medication, it often leads to relapse, which then has a detrimental effect for the ability to recover in the future. So each subsequent relapse makes it more difficult for people to get better. So I think this slide's really interesting. This slide was actually the journal cover of the journal Obesity from a few years back now. And this is what's on the screen is actually an MRI of a person that has obesity. And what I think is really interesting about it is that it goes around and it shows a number of the illnesses and diseases that you're at greatly increased risk of if you develop an obese BMI. And you can see it really does just about affect every body system. And you go, yeah, there's a lot of life-shortening things there, but it's really easy to talk about life expectancy stats because they're easy to grab. But what I think is even more important than the life expectancy is people's quality of life. Now, if you start developing any of the things that are around this image, you go, well, those things are really going to reduce people's quality of life. And so that, for me, is where the emphasis needs to be. And it's about early intervention to stop people, yes, dying prematurely, but way before that, to improve their quality of life by them not having lots of physical health complications. Now, is there a health inequality for people that experience severe mental illness? Well, what the research says, and what I've clearly observed over many years working in mental health, is that there is. So even though there's these much higher risk factors for cardiometabolic disease that people with severe mental illness experience, they actually have lower rates of cardiovascular risk monitoring than the general population. even when items are diagnosed, whether it be high blood pressure, glucose abnormalities, whatever risk factor is identified, it is less likely to be adequately treated than someone from the general population. This is despite, on average, this population of people with that experience severe mental illness actually attend primary care more often than the general population. We've also seen much lower rates of vaccinations in this thing. So this is a problem. And what some people that have worked alongside people with mental illness, whether it be in primary care or specialist mental health services, have said, oh, well, you know, people aren't really motivated or interested in looking after their physical health. And it was really important when this national psychosis survey took place. So this was a survey that's been done twice, and we're hoping to convince Mark Butler to fund it again for a third round, because it hasn't been done since 2010. But really wide scope of better understanding what people with severe mental illness experience in society. And just pulling out one little question of what was a really big survey and interview process was they asked people what was the most important challenge over the coming year. And for people that work specifically with people with mental illness, the top three things will not come in as a surprise at all. Financial issues, being lonely and isolated, and lack of employment. What actually did surprise a lot of people was in at number 4 came at poor physical health and physical health issues, which is interesting because where we tend to focus as health services, we spend far more time looking at number 5, uncontrolled symptoms of mental illness. So we focus in and put a lot of energy and emphasis on there, but there's a somewhat neglect of the poor physical health and physical health issues. Psychiatrists have often felt like it's out of their domain area. Oh, I don't know much about that. I haven't done that since I was, you know, training. And for GPs, it's a complicated issue because there's lots of time barriers, and there are definitely communication issues as well with the with mental health services. So, but what I really want to make clear from this slide is it's not through a lack of interest or lack of concern from the people that do actually experience the severe mental illness. It is high on their agenda that their poor physical health is there and that they'd like to do something about it. So what's the process by which these cardiometabolic risk factors that lead to poor quality of life and premature death start to occur? Well, when we draw together information from different studies, we can see that when the psychosis first occurs, it's not immediate like, oh, they're different from the rest of the population in terms of their cardiometabolic risk. When people are early stage psychosis, before they've started medication, when they're medication naive, the rates of metabolic syndrome is only at about 6%. First episode psychosis, so we're talking within the first 2 years of antipsychotic treatment, that rate of metabolic syndrome more than doubles within that first 2-year period. And by the time people have an established mental illness or enduring mental illness, when we look at rates of metabolic syndrome for that group, more than half, up to 62%, depending on the study that you look at, actually meet criteria for metabolic syndrome. So what we can see from that, and then we add in the extra risk factor of tobacco that I was mentioning at the start of the presentation, which really, you know, we know that when people smoke, smoking is more likely to be the cause of death than all other sources combined. So it is quite a precarious pathway when people are diagnosed with psychosis and put on treatment to manage and deal with that psychotic illness. when we look at the process from starting antipsychotic medications and what happens with weight gain, we can see here that over the weight gain is skewed towards the beginning. So the greatest gain happens at the start. So you can see there that within 2 years, people on average are gaining over 10 kilograms in their first 2 years of treatment. Unfortunately, for most people, antipsychotics are required medication ongoingly. And although the rate of weight gain that people put on does slow slightly from that rapid pace at the beginning, it is still significant. So year 3, another 4 kilograms, year 4, another 3 kilograms, and that trajectory continues. But the real issue is what happens at the start, and then the weight gain on top of it. It's a little bit like if you're lucky enough to have a big bank account and the compounding interest that actually occurs there. So you're building on what is already a really significant problem. So that's kind of the trajectory. But I want to take you back right to the beginning of when people first start on antipsychotics. And one of the interesting things about this study is they used healthy volunteers. So these were people without psychosis that agreed to participate in a study where they were given antipsychotics for a 4-week period. And what we can see within just that 4-week period with people that are otherwise healthy, we can see that the antipsychotics have an acute and very direct impact on both weight gain and the development of insulin resistance in a really short period of time. So we need to be very mindful with our use of antipsychotics, and we need to look at intervening right from the start. As soon as someone starts on an antipsychotic, we need to be thinking about, okay, well, there's going to be weight gain and metabolic complications associated with this medication. How are we going to manage that? And it seems to be somewhat acceptable in psychiatry in a lot of areas that it's like, well, it's just what happens, and go off and see your GP about that. But I always say, could you imagine the outcry in oncology if they started someone on chemotherapy and the person comes back and, oh, my hair's falling out, I feel nauseous and terrible, I've got all these symptoms. And the oncologist just said to them, oh, just go see your GP about those. There'd be absolute outrage. Yet, to a degree, that is what happens in mental health, and that needs to change. So I did just want to speak to everyone in the room, but particularly to the prescribers. Any GPs or other prescribers in the room and people that advocate on behalf of others, but information in terms of selecting an antipsychotic medication. The research really clearly says, when we pull together all the big meta-analyses, that no antipsychotic is more effective in the treatment of positive symptoms in acute schizophrenia, with the exception of clozapine. Now, anyone that's not familiar with clozapine is something that is reserved and held back. It's a very effective medication for treatment-resistant schizophrenia. It's the gold standard. It works better than anything else, but people require regular monitoring for that because there's a risk of developing some very severe side effects, including agranulocytosis, where people's white blood cells drop and make them very susceptible to infections that their bodies can't fight, which creates a risk of death. So clozapine is only utilised when other medications have failed to work. So what we've said is that there's no real difference, no significant difference in the treatment of positive symptoms between the agents. However, there are major differences in the side effect profiles between agents. And we've spoken about weight gain. Obviously, it's not the only side effect associated with antipsychotic medications, but it is the weight gain and the cardiometabolic are the most prominent. Now, what you're looking at on screen is what they refer to as a frequency chart. So The more pluses, and you could have up to 3 in any one box, that means the more likely that side effect listed along the top of the page is associated with the particular antipsychotic down the side. And I mentioned clozapine before, but that is held back because it causes some severe side effects. That includes some severe cardiometabolic side effects you can see highly frequently. But there's another medication that is has been on the market for quite a while, and it has been very popular. However, it also causes lots of complications with weight gain and metabolic disturbance. So we need to be really cautious about the medications, and we can see here that all are not even. And ideally, what we want to do is try and choose medications that are less likely to cause side effects. It's not a hard and fast rule, but I would say that the general rule is that the more recent the release of the medication, generally the softer its side effect profile. And that's because antipsychotics have been refined over time. So I did just want to really talk a little bit more about olanzapine because it is an issue. It's the default treatment still for lots of psychiatrists, but also lots of GPs. But I just want to point out that guidelines are really clear that it should not be used as a first-line treatment. So rather, it should be thought of a little bit like we think about clozapine. If we can't get other medications to work, then we can try olanzapine. We don't want to exclude it totally because we want everything possible in our arsenal to deal with this. But the College of Psychiatrists have had it in their guidelines since 2016. Origin Youth Health, who are from Melbourne, and they're the world leaders in early psychosis, have had it in their guidelines since 2014. And the Port guidelines, which are from the US, have had it in their guidelines since 2010. And very interestingly, olanzapine is hardly used in the US. And the reason why is that patients started suing their treating doctors for putting them on this medication when there were safer alternatives and also didn't advise them about the risks. So the reality is that scared everyone off in the US, but still it's a dominant medication in Australia, but that needs to change. And also the other part of the guideline is right down the bottom there, and I'll get to this a little bit more when I'm talking about the resources, but lifestyle interventions should be introduced at the time of antipsychotic initiation. Now, we know that disadvantage in society is not a level playing field, and mostly healthcare in Australia, which, you know, by world standards is really good quality. Okay, most countries have got it much worse than Australia. However, Medicare and similar systems apply what we would call an equality model. So everyone gets access to the same amount, basically. So if you think of you know, the person in the blue shirt being Gina Reinhart, they're getting the same Medicare rebate as someone who might be really struggling to make ends meet, living with a severe mental illness on, you know, maybe on welfare, but using most of their money to pay for their very expensive cigarettes, which they're addicted to, which doesn't allow them. So what we really need to try and move towards with populations like this is Gina probably doesn't need our backup. She's probably not going to like that picture either. She'll probably try and get that one removed from the art show too. Sorry, Gina. And then the purple top. The idea is that we give people an extra leg up, and I guess that's what, you know, things like the NDIS have set out to achieve. However, you know, the way that's been applied in mental health is not necessarily the right method. The NDIS has been well intentioned, but also it probably hasn't been well directed and a little bit rushed. I did so in the name of trying to provide a bit of equity. I've worked together with teams when I worked with South East Sydney Local Health District in keeping the body in mind, and in more recent times with Mindgardens Neuroscience Network to really help develop clinical frameworks where we show, okay, well, this is what we can do, and we're going to demonstrate that we can actually, in clinical practice, address these cardiometabolic issues, primarily with lifestyle interventions. We've really contributed to the evidence space in terms of what is in there in the literature, and also shaped guidelines both here in Australia and internationally. If anyone is interested in going away and looking at what all the evidence is for physical health care for people with mental illness, what works, what doesn't, I can save you going on a big search and pulling together lots of papers and reviewing them, because it's all done in one very nice piece. And this was a commissioned piece by Lancet Psychiatry that has pulled together all the evidence around lifestyle interventions, what we've got that shows evidence that works, what we've got that's not so good, and what we should be doing more of. So I would encourage you to have a look at that if you have got an interest. Now, I don't want to bang on too much about research today, but I did just want to show you what's possible and what difference interventions in the clinical space can have. So I had been plugging away with my small team in early psychosis at trying to make a difference to people around their metabolic health outcomes. And we'd been doing that for, 5 or more years, and we got some money from the New South Wales state government to evaluate what we'd been doing. And we were kind of faking it till we made it until we got that funding, because the allied health that we brought in was kind of like, oh, we'll utilize exercise physiology students on placement, and we'll utilize dietitian students on placement, and we'll beg, borrow, and steal to basically get these happening, because these, especially exercise physiologists and dietitians at the time, they weren't utilized in mental health. It was that part of allied health was a completely foreign concept. And so bringing these specialist staff on board, what we were able to do is compare the outcomes of our group, which was everyone that was admitted to the early psychosis program at time, versus another site which had an identical setup in terms of early psychosis, but didn't have the lifestyle intervention add-ons that we had. And I just want to highlight some of the differences. So the control site had a nearly 8 kilogram increase in weight over a 3-month period of time. Now you might say, oh, that's incredible. That's like so bad. But that is really consistent with what all the studies show. Around about 8 kilos is the average weight gain in the first 3 months of treatment. When we introduced lifestyle interventions and worked with people around that to help them with goal setting around their exercise diet, and had practical interventions with gyms and group work and cooking groups, we got that weight gain down to 1.8 kilos, so less than 2. But that's not the whole story. There was a really significant difference on waist circumference. So instead of gaining over 7 centimeters of waist circumference, the change was negligible. And the reason we hypothesized there was some weight gain is because a lot of the young people, especially young males, were actually got so enthusiastic about the gym, they started putting on some muscle mass, which might indicate some of the weight gain. But what's the most important thing here? This was really naturalistic. So it wasn't just, would you like to sign up to be in this study? And we only took enthusiastic volunteers. This was everyone that came in the program. So we just made it part of standard care that these lifestyle interventions were there. One of the other measures we looked at was the amount of people that gained clinically significant weight, which in the research is represented by gaining more than 7% of your pre-treatment weight. So did we stop everyone from gaining clinically significant weight? No, we didn't. 13% of the participants still gained clinically significant weight. And that's to be expected, really, and probably expect more than that, because people are coming in and there's going to be people, oh, I'm not really motivated about, I'm quite happy with my diet or my exercise. So we're not going to change everyone. But compare that to where an intervention isn't offered, and 3/4 of people that enter that program within 3 months, they've gained clinically significant weight in that time. So really speaks to, the value of that. We've had a lot of people that have had a lot of foresight and faith in the program and funded us ongoingly. And what we've been able to show is that those results weren't a one-off, everyone putting in extra effort because it's a study thing. What we've been able to show over many years is that making it part of routine care and delivering this intervention over years, we've been able to demonstrate the same results over and over again. So lifestyle interventions really do work to attenuate or prevent that weight gain in the first place. So, which brings me to Mindgardens, which keeping the body in mind is one part of Mindgardens. Much of the team that is now Mindgardens used to work in Southeast Sydney, and I work closely with keeping the body in mind. We're now part of this wider network. The other group that I wanted to give a shout out to was Equally Well. Now, Equally Well do a fantastic job in advocating on a national level for people with severe mental illness around their physical health, and striving for them to have much better health outcomes, ultimately the same as the general population. So to get to the resources that I'm talking about, again, the QR code is there and it'll pop up a few more times. We developed a series of resource packages. They were done with a co-design practice, which is what is favoured in mental health, that we work together with the consumers who use our services to develop those resources. So some of these resources were digitised and updated from previously developed resources, and we've got both consumer and clinician-facing resources, and it was generously funded by the Mental Health Commission of New South Wales. So the cornerstone of these resources is the cardiometabolic algorithm. Now, this has been developed so that both people working in specific mental health settings, but also in primary healthcare settings, can actually go, okay, well, how do I manage the physical health of people with mental illness? And I did just want to say that this resource, it started as a training guide for, initially a one-off registrar training. It is now been adapted in 9 different countries and is in actually 5 different languages and really widely used around the world, including very prominently in the United Kingdom. So this is what the health resource looks like. And just to break it down on how it works, the idea is we want to make it as simple and friendly and easy to use as possible. So up the top, we've got the related health issue, whether it's a lifestyle issue, obesity, blood pressure, glucose, lipids, or sleep. Then we have a red zone, which tells us where we want to intervene. But before we even get there, you'll notice a yellow line underneath the blue boxes. And that is because we know that as soon as people start on antipsychotics, we know that a problem is going to emerge. So why wouldn't we be intervening early to try and get something? So lifestyle advice should be happening from the start for diet, exercise, smoking prevention or cessation, and co-managing the physical health with expertise. So if it's within the mental health service with GPs and vice versa. Now, the red zone, you might look at some of that and go, oh, that's pretty conservative, some of those numbers. And yeah, rightfully so. We've modeled this on what we see for Aboriginal Australians and the cutoffs there. So we know that population is increased risk, but we also know that this population of people that experience severe mental illness is also at increased risk. So we can see things like, oh, BMI, okay, well, we're over it if we get a BMI over 25. Well, we know a lot of the population has a BMI over 25. Yes, it's true. But this population, we need to make sure, because the escalation of problems happens so quickly. So if people hit the red zone, well, the first thing we want to do down in the intervention yellow section is we really want to intensify and individualize those lifestyle intervention with structured nutritional counseling and physical activity. And also, do we, a medication review? Sometimes people are started on medications, especially in acute settings, and they don't necessarily need to be on that medication or multiple medications for the long term. It's just that they might have been discharged from hospital in a hurry and gone, here, over to you, GP, your problem, without much of a discharge summary, and saying, well, we would advise that over this period of time that this medication could be phased out. So people often end up on multiple medications for much longer term than they need to. And then we've got individual responses for what interventions should look like if people are in the red zone and that they're not responding to lifestyle interventions to bring things back in order. Ultimately, we've got a target zone of the green, which is, generally speaking, the inverse of the red zone. It's just designed to, like, okay, this is the target. It's aspirational in many aspects, but really we should be still plugging away heavily in the yellow zone if we haven't got to the results in the green zone. The flip side of this resource actually provides us information on monitoring. So how often should we be taking people's weight and waist and blood pressure and lipid profile? And you'll notice that it is more often than we would advocate for the general population, and that is because the risk. And of particular note is the first 6 to 8 weeks, because antipsychotics have such a severe impact when people first start. It is strongly recommended that weekly monitoring, especially of weight, happens in that time to say, hey, what's going on, and making sure things don't get too out of control. On the right-hand side of this page, we've got information around what to do when we might be reviewing antipsychotics and mood stabilizers, but also what specific pharmacological interventions are available. I would say that in addition to this resource, at the on our website at the QR code, we've got an extensive evidence guide that has traced where all of the advice from this form has come from. So if people go, oh, I didn't know you could do that, or I'm not sure if that's the best way, we've got the evidence there really clearly marked out for people. We've also developed a guide that sits alongside that is for people that are adolescents and commence on medication. So it looks fairly similar. There are some differences, especially around what cutoffs are and measurements, and utilizing percentile charts and the like. So that's just to guide people when antipsychotics are given to adolescents. And the same, we've got that specific advice on the back page. And again, that also comes with an evidence guide. Really importantly, I've spoken about the tobacco smoking rates amongst people with severe mental illness. And we really wanted to support the cessation with that. And there's 2 forms of this. So we developed a simplified tobacco treatment framework to give people, allied health, and also everyone working with this population, an overview of what are the important elements. So things like making sure that we're offering support through CBT or motivational interviewing throughout the time that people quit smoking, regularly reviewing people for nicotine withdrawal symptoms or adverse reactions from treatment, asking, advising, and helping people who want to quit into that thing is really vital. one of the things, you know, we know about NRT and we know that that's helpful and things like that. But what we've been scared off with, and particularly for people that experience mental illness, is varenicline, or its brand name Champix. Now, Champix at one point in time had a little black box warning saying don't use in people with mental illness. And that has stuck with people. But I can tell you categorically that that has been debunked, and there is no increased risk for people on varenicline for developing neuro-adverse side effects compared to other groups, or compared to other methods of quitting, like NRT, like bupropion, like going cold turkey. So there's no increased risk, and that has categorically been disproved. So don't let that warning scare you off. Varenicline is actually a really effective drug, and for a certain percentage of people, it's like a magic bullet on smoking. People start taking varenicline, they go, you know what, I just don't feel like smoking, and it's just a life changer. And so we want to use that as a first line option for most people on psychotropic medication, because it will work. NRT can be used alongside at the same time as varenicline to improve its effectiveness. That's safe. When we're using NRT, we want to use a combination of both the long-acting, which is the patches, and short-acting, which is essentially any other form, which is mainly oral. And NRT can be started before a person actually commits to quitting, so they don't have to agree to quit fully. They can put patches on and they can keep smoking, and they will self-regulate. Okay, so there are the main things. There is a much more comprehensive guide that goes into much more detail about how you use the medication and when you use it. So please refer to that as a guide to, okay, well, how exactly do I do that? On the rear, again, we've provided lots of information and kind of really helpful pieces about withdrawal symptoms, and especially the interactions. We know that there are some interactions with some antipsychotic medications and other medications. So we need to be mindful of that. And it's not that those things should not be used when people are quitting smoking, but rather that they should be monitored. So it is safe for people to quit smoking. There are just sometimes things that we need to monitor in terms of medication levels and potential increase of side effects. And we've got a little problem-solving guide down the bottom of some of the problems. Again, that's supported by an evidence guide on the website. In terms of, okay, well, how do I work with someone that is experiencing severe mental illness around lifestyle interventions? We've developed videos on how to do that. So please check that out. We've also developed a number of consumer-facing resources, and these are essentially consumer learning modules that have been arranged around a base goal-setting module. So the idea is to go into the goal-setting module, work out where your goals are, and then people can use individual guides or modules to meet the needs of their actual goals. And so you can see here we've got across a range of lifestyle and general health settings. So they're all available. They're designed that individuals can use them, but they're also designed so that they can be used in conjunction with a carer, support person, or clinician. Just very quickly, oral health outcomes are also terrible for people with severe mental health, and we've alongside Nemo, we've developed some oral health guides, both how to look after your oral health, but also how to get assistance with maintaining your oral health. So that's some of the things that are in this extensive package. It's this stuff has been put in the physical healthcare guide for people living with mental health issues as part of New South Wales Health, and I'm very mindful that I've probably gone over time, but that is the end of the presentation, and I see that maybe a couple of questions have popped up, but I don't know, Carleen, whether you want to pop on and coordinate that process.
Thank you so much, Andrew and Joyce. It's very inspiring, I have to say. And we would like to encourage everyone to use collaborative practice to improve patient outcomes. For general practitioners, the chronic disease management Medicare items are an easy way to link with allied health. Medicare will subsidise the first allied health visits for your patient, but be aware there's only 5 visits allowed. So it's really just a start-up. And these are going to be changed sometime next year. They haven't actually told us, well, it's supposed to be July next year. Just a reminder that medication review is not really part of that because HMR and RMMR both have their own Medicare items. We hope you enjoyed the presentation tonight. I certainly did. Thank you, Joyce, and thank you so much, Andrew. It was very inspiring. I've got a couple of group homes that I go to that I'm going to get onto your website tonight, print some stuff out for them. So the Allied Health Network would really like to thank Central and Eastern Sydney Primary Health Network for their support for this presentation. And thank you, attendees. You've been wonderful tonight. And I'm sure you're going to complete the evaluation and self-record your CPD. Thank you so much.
Thank you
Thank you so
all.
much, everyone, for joining, and thank you to our presenters, Carleen and John, as well, for organising tonight's session. Enjoy the rest of your night, everybody. Thank you.